Before we get started with the clinical panel, there's a very special video we'd like to show you from the foundation.
She was diagnosed in August of 2019, and it was very scary. We didn't know what to expect. The greatest struggle is the fact that it's taken her voice away. I miss the sound of my wife's voice. I haven't heard it for 2 years now.
When I was trach in January 2021, I lost my ability to speak. I don't like having ALS, but I never ask why me? Because why not me? What makes me better than anyone else not to have it?
As a family, we have come together in order to navigate the diagnosis of ALS. You need patience. We were assigned a nurse with Les Turner. Her name is Julie. And so we meet with Julie once or twice a month to talk about the symptoms my mother is having, what her needs are, and to see what resources can meet those needs. And that has been so helpful, especially during those times where we were just unsure what to do next.
Julie has provided us a wealth of information, enlightening us to things that we didn't know existed. She informed us of grants for modifications to our home. We were actually given a grant so that my wife can have a curbless shower in our new home. That was invaluable.
Julie is well informed on what's going on at Les Turner. She has made sure I have all the information I need.
My mother, my shero, I am right there by her side. Before her diagnosis, we talked every day. And since her diagnosis, we talk more. To see her every single day say, this is my journey and I'm gonna keep walking. It's amazing.
My wife is undoubtedly the strongest person I've ever met in my life. There have been times when I've had pity parties, and she has also, but then we come together and glean strength from each other and keep on going.
I just want to say again how grateful and thankful for my family. My husband is my superhero. My heart is so full for him. Danielle and Mike I'm deeply grateful for as well. And the Les Turner Foundation, I can't sing their praise enough. Thank you, Les Turner. I appreciate you.
Okay, and so now I'm going to introduce the panel. And for those, some people are just joining us, so bear with me. I'm going to reintroduce Dr. Maragakis and as well as the rest of the panel to the audience here. It's also in your handouts, so please take a look at that if you want to follow along. But Dr. Maragakis is the medical director of the Johns Hopkins ALS Clinical Trial Unit and director of the ALS Center for Cell Therapy and Regeneration Research and professor of neurology at Johns Hopkins University. I'll summarize his research in saying that we just had an excellent talk. He's clearly an innovator and has taken advantage of this powerful tool of precision medicine that is induced pluripotent stem cells. We'll probably pick his brain a little bit about stem cells in general, both for modeling the disease and as a therapy during the conversation today. We're really lucky to have him on the panel because he's also heavily involved in clinical research as a PI on, or co-PI on numerous clinical trials in ALS. So we'll be getting information from someone who's really at the forefront of what is on the horizon, what's coming down the pipeline, and things that have already been through clinical trials. In addition to that, he's coordinated within the NEALS Consortium, which is the Northeast ALS Consortium, served as an executive board member for NEALS, and is currently a member of the Scientific Advisory Board. My mentor, fellowship director, Dr. Driss, here, to the right of Dr. Maragakis, is an associate professor of the Ken and Ruth Davey Department of Neurology at Northwestern University School of Medicine, where she also served as the director of the Neuromuscular Medicine Fellowship Program, training some of the brightest minds in the field of neuromuscular medicine and ALS. And then I think I'll just sort of summarize it, because she's done many things in her career, including has done a lot of research in ALS genetics, where she's an expert in that. And she's also been really the point person over the last number of years in leading the Les Turner ALS Center's clinical trial program, and really building up to, I think, levels that we haven't seen, I'm not sure ever, in Chicago with clinical trials that have been going on, thanks to her. Dr. Coleman is an associate professor of medicine and pulmonary and critical care medicine and neurology, and a member of the Les Turner ALS Center at Northwestern. He's one of two world leading experts on pulmonary medicine and ALS, along with Lisa Wolf, who's in the audience here. Dr. Coleman and Dr. Wolf are an absolute difference makers. They make our clinic, I think, really special, and one that I think when we take care of patients with ALS, probably some of the most important things we've done historically, and continues to be one of the most important things, is we take care of the breathing. So Dr. Coleman, over the last 10 years, has served in the clinic, the Lois and Solia ALS clinic at the Les Turner's ALS Center. He is also the head of the Les Turner Support Service Committee and is on the board of directors for the Les Turner Foundation. And lastly, Lauren Webb. You want to wave, Lauren, at the end? So Lauren is the director. I just wanted to make sure you're down there.
Yeah,
Is the director of support services and education at the Les Turner ALS Foundation. Lauren has worked in the neuromuscular community for over 20 years, providing direct patient care for individuals with ALS, working for a neurological specialty reference lab, coordinating clinical trials at the Ann and Robert H. Lurie Children's Hospital of Chicago, and overseeing the Muscular Dystrophy Association's nationwide care center network. She's got a master's degree in social work with a concentration in health administration and policy from the University of Chicago. Lauren is a devoted advocate who approaches people and problems with humility, curiosity, and humor. It's not good to have me reading so much when I come up here, because I'm just like excited to be in front of the audience. So it's like the hardest thing to do. But I think the next part of the panel will be really a lot of fun. We're going to start off with a mix of questions from the audience here. So if anyone wants to go up and ask a question, we'll bring a microphone to you. Just wave your hands or go up to the microphone. And we already have one coming in. We're going to take a blend of questions. We have got pre-submitted questions as well. But let's start off with one from the audience, and we'll be watching also for the chat. I have that in front of me as well if you're listening online. Dr. Wolf.
So this is a question for Lauren. And in the last year, I know that last 2 years, you've done a lot of work looking at decision-making and shared decision-making. And I wanted to know if you could maybe explain to the audience, what is shared decision-making and how does it hope to change how we care for our patients with ALS?
Thanks, Dr. Wolf. So we started this journey looking particularly at shared decision-making. So it's where we empower people living with ALS and their caregivers to really think about some of the decisions that they have to make. And it's really incorporating through education, through health literacy, right? So writing things in a way that people can understand, and leveling the playing field between families and clinicians. And we really think that that is a critical component of decision-making. But some of the key things in the literature around decision-making is that it doesn't happen in a vacuum, right? You know, I have a kid going off to college. How can I afford this? You know, there's different priorities, there's different trade-offs. And we really want to stress that there's no right decision, it's only your decision. And I think that that's really critical and key. And so we developed in collaboration with people living with ALS, caregivers, and researchers, and our clinic team here, John, did a lot of editing of documents for us. But we created a tool called My ALS Decision Tool. And that is a way for people to make decisions to do an interactive guide to help make decisions. So right now we have decisions around non-invasive ventilation and around a feeding tube. So those are some of the core things that we've been working on, trying to better understand from a person living with ALS perspective, what's important for them. So having that interactive component allows and facilitates for more conversations.
Great. Is there anything anyone else wanted to add? I'm going to start one off then for our visiting professor, Dr. Maribel. So I guess there's a lot of interest in the questions that have been pre-submitted about stem cell treatments. And so I thought maybe, because there's always this thought that with induced pluripotent stem cells or patient-derived stem cells, that in addition to learning about what you've elegantly showed, it could be a valuable tool to generate data and test out drugs. Could they themselves be used as a therapy, and how would you go about doing that?
Well, I spent about the first 15 years of my career thinking about stem cell transplantation, specifically glial progenitor cells, and in a collaboration with a company, actually had an IND from the FDA. I think over time, my take on it with regard to stem cell transplantation in the spinal cord or in the brain is that it's probably not ready for prime time. And I say that because ALS is a disease that affects the entire neuroaxis, the brain and the entire spinal cord. And so until we can find a way to replace cells or transplant cells in that fashion, I think we have a ways to go. Secondly is that I think would be I think sometimes patients feel like stem cells will actually allow them to become stronger. And here in 2022, I just don't think we have the technologies to be able to grow nerve cells fast enough to make a difference with regard to actually improving strength or improving function. And so, the short answer is, with regard to stem cell transplantation to replace nerve cells or to replace astrocyte cells, I think there's a long way to go. And I think there are probably a wealth of drug targets to keep cells alive that are currently there that probably preclude that. There are some interesting studies going on with regard to mesenchymal stem cell transplantation from bone marrow derived, and there's some kind of early interesting data in that respect. And I think we'll stay tuned to see how some of those data shake out. But what I tell patients practically is I don't view stem cells as a panacea, and I think we've got to still have a ways to go.
Since you mentioned it, I know that there's a lot of interest in neurone, which I think you were alluding to, but that would be the mesenchymal stem cell transplants data that you're referring to. Okay, could you give us a little update, because a lot of patients are kind of confused why that's not approved or why that's not available yet, and maybe since you worked it into your answer there, you just led me to that.
Well, I won't speak for the company because I don't know that I don't know the ins and outs of their specific plans, other than to say, based on the published data, I think they've got some interesting biomarkers that they've demonstrated. I think that's basically what I would be able to say.
And I chuckled to myself because I knew how unfair of a question that is to ask you to talk about that clinical trial, which I know you're not running. Not because I'm trying to chuckle about the trial itself. Actually, I think that it's a really interesting approach that we've been talking about for a long time, and I think there's been great preclinical studies on it that suggest that there could be an effect, but not a reversal or a cure with that approach. Although there's maybe more sophisticated ways also down the pipeline with re-engineering the stem cells that you transplant, as I think I've seen Clay Svensson's group do. But it's interesting. It comes to a question of, it's interesting the things that end up getting a chance to go to that platform and how you translate things to the clinic. And if I could ask you one more question, because you've been at the forefront of stem cells, you've done gene therapy work, and could you talk a little bit about why is it one idea comes from the bench to the lab, the bench to the clinical trial, and why other ideas that seem to be really promising and in the bench don't make it there in terms of IP and other things involved? Because I feel like that is something that is sometimes lost on me as a scientist in terms of what it takes to get your idea from the bench to the clinic.
Well, I mean, it's so getting a drug, it doesn't have to be an ALS drug, getting a drug from the bench to clinic is, I think the numbers takes 10 years and the failure rate is enormously high, and it can fail at different times, right? It can be in the laboratory where a drug just doesn't work, or it could be in an animal model where it doesn't work, or it could be that a drug is toxic. And that's why I think it's important to do clinical trials in the right way, right? Because we don't want to also hurt patients. And even though drugs seem to be safe, we know in the context of ALS that it's not that a drug does nothing or it makes patients better. It sometimes can make patients worse. And we've seen that in the context of ALS with a couple of different drugs. So getting drugs to patients is hard. And I don't mean to be, it's just they don't work at several different levels. It could be toxicity, it could be lack of efficacy, it could be it could be IP, it could be funding. There's a lot of ways that drugs fail. And so those that do make it to clinical trial, so I tell patients that I don't have necessarily a horse in the race for any of the trials that we're running at our institution, but I can tell them that we will only run a study that we think is scientifically sound.
Can I ask a question?
Perfect. Yeah, we'll take one from the audience. This is Dr. Ajroud-Driss.
Thank you so much. So I remember when I first joined Northwestern, there weren't really clinical trials, or as far as I know, there weren't. But I know now at the Les Turner Center, there are multiple clinical trials, ongoing clinical trials. And, this is also in part thanks to Dr. Senda Ajroud-Driss, because, she moved the Les Turner Center to the NILS platform. And can you give us an update, like how many clinical trials there are now, how many active ones now? Can you tell us more?
So thank you, Hande. Let me correct you a little bit. So the reason why there weren't that many trials is there wasn't that many compounds to be tested way back too. So, and really it's interesting now, there is a tremendous interest for ALS. And Dr. Maragakis showed that in his slide, the number really increased tremendously. There are many, many trials. I haven't counted them. I wish I did. But we're doing very interesting trial. We're doing gene therapy studies, and we're doing phase 3, phase 2 study, and we're going to be doing a phase 1b study. So we're doing study for multiple kind of area of the disease for patient early and for patient late. We've also have done expanded access program recently. So we're trying to make sure there is an opportunity for every patient to participate in a clinical trial if they're interested to. But I think we are living extraordinary times now with the almost explosion of new compounds that are getting in the arena.
Okay, I have another question, but this one's going to be coming online and we'll direct it to Dr. Coleman. For a person with this is from Callie. Thank you for submitting your question. For a person with bulbar ALS dependent on BiPAP, what other therapies can be used to keep respiratory system as healthy as possible? Prevent infections, for example. Also, how best to manage secretions is to keep secretions manageable without causing dental issues from dry mouth.
Thank you, Callie, for the question. Try that again. I'll try to address it in a couple of different points here. So in terms of, when we talk about respiratory failure in people with neuromuscular disease or ALS, the main problem is that your diaphragm muscle, which is the main muscle that helps us breathe, gets weaker over time. And people can present with weakness in their diaphragm muscle in a variety of different ways. And the therapy that helps people support their diaphragm muscle is non-invasive ventilation or a BiPAP machine. And when you talk about non-invasive ventilation, it comes in a variety of different forms, but it is usually a therapy that people wear nocturnally initially with a mask. And the mask comes in different styles to help support those respiratory muscles. It's not to completely make your muscles weaker, which is a common question I get asked. Is there to support your muscle so it sustains the strength of that diaphragm muscle. Bulbar patients present a unique set of challenges because of all the oropharyngeal weakness. And so, sometimes there's a difficulty tolerating non-invasive ventilation. And so we work to desensitize people with bulbar disease slowly over time. Historically, they have had less tolerance to non-invasive ventilation than people with limb onset disease. But more with the advances in non-invasive ventilation, we've seen greater numbers of patients become adherent and benefit from non-invasive ventilation. When we talk about secretion management, so that's a huge problem, right? Especially with patients with bulbar disease. And so we approach it in a variety of different ways. My personal approach and something I share with Dr. Wolf is I always ask people kind of where they are on a scale, right? Because, bulbar disease is this excessive drooling, these secretion management problems where, the bottom of their mouth is really wet and the top of their mouth is really dry and the tongue doesn't work to lubricate the top of your mouth. And so what is the lesser of two evils, right? Is it too dry or too wet? And so, I usually kind of have people tell me where they feel on that scale, and then we can address that with different medication therapies to help decrease the production of saliva. Sometimes it works, sometimes we have a variety of different ways we approach it. We approach it sometimes with medical therapies or pharmacotherapies, and then sometimes we talk about Botox injections, which are a little bit longer therapies, and then we talk about radiation therapies to help kind of relieve it long term. But those are kind of how we approach it. I forget what the other question was there. Okay. If not, I can answer more later.
Yeah, I think you covered it, but I'm going to ask you a follow-up question. You keep mentioning non-invasive ventilation, and I know that a lot of the audience will know what that is, but what would be that, compared to what's invasive ventilation, what's non-invasive ventilation, what are our options? Why not just oxygen?
Ooh, loaded question. Okay, so non-invasive ventilation. So when we talk about ventilation support, we talk about it in two different ways. So if you think of someone that may get sick, or you may watch a TV show and someone's on a ventilator, right? So they usually have a breathing tube that is going down their throat and providing ventilation support. That is usually when people are acutely ill. And when they need more long-term ventilation, they need what's called a tracheostomy, which is a surgical airway placed in your throat that prevents the ventilation, that promotes ventilation support. Kind of like what we saw in the video we just watched. So mechanical ventilation or invasive ventilation and non-invasive ventilation both serve the same purpose, which is to support your respiratory muscles and provide good exchange of oxygen and carbon dioxide. When we think about, people with neuromuscular disease, most people with neuromuscular disease do not have problems with their lungs per se. So it's not a problem getting oxygen in and out of their lungs because their lungs are bad. It's a problem because their muscles aren't strong enough to bring that oxygen in and out. And so giving someone supplemental oxygen with neuromuscular disease actually confuses your brain. So our brains think, okay, if I have low oxygen, I have to breathe more times. And if you give somebody with neuromuscular disease supplemental oxygen, it confuses their brain to say, okay, well, now I have all this oxygen I need. I don't need to breathe as often. And it actually makes their carbon dioxide rise higher. So it's not as beneficial for them. And so if someone or love has neuromuscular disease and they have low oxygen levels, the first therapy always is to support those respiratory muscles with non-invasive ventilation support. Getting back to your first question about non-invasive versus invasive ventilation. So invasive ventilation is done through a tracheostomy, non-invasive ventilation is done with a mask. Both provide similar levels of ventilation support.
Thank you. And I'll keep my eye out, but if someone needs us to bring a mic over, just wave your arms. Keep that in mind. We're happy to come to you. I have another question online. I haven't decided who this is going to go to yet, so you guys can volunteer. Someone is making a comment, actually. It's a myth that ALS is non-painful, as many PALs complain of debilitating pain. As clinicians, what strategies can you recommend as traditional therapies like baclofen, gabapentin, or epidurals aren't sufficient for many, I guess, to treat the pain? What's your approach to treating pain in ALS patients? In fact, I do recall a paper that came out of the Les Turner Center on pain in ALS patients.
Well, thank you for your question. Yes, we actually looked at it, and ALS depending on the stage of the disease, there is pain with it. Early on, it's cramp, and then a little bit later in the disease, it's positional pain. There is no one treatment for everybody. It depends on what kind of pain people have. And usually in the clinic, we do ask patient about it and try to help them. So if it's cramp, there is a way to treat it. Yes, gabapentin or baclofen may help with that. But we need to also understand later on what the problem is. And sometimes increased tone or spasticity with the spasm could be very painful as well. And for that, there is a different treatment. So baclofen or other muscle relaxant may be the way to do it. So I don't think there is a one way to do it for everybody, but I agree with you, pain is there. And it's important if your doctor doesn't ask you to bring it up because there are treatments for it.
Anything else to add?
There's a question. Yeah.
Yeah, no, we see the question. Happy to take it.
Okay, Dr. Colin. Sorry.
I just want to say one other answer. I know I'm not on the panel, but shutting me up.
Okay, this is Dr. Wolf. She's not on the video feed, but she's in the audience. And
so one of the things that's super important is prevention of frozen joints, frozen shoulder being the one that we see the most. And one of the things that we talk about to patients early and upfront in disease is the importance of range of motion and partnered range of motion exercise to prevent the pain, because it's easier to prevent it than to try and treat it at the other end. So, you're the PM&R guy. I'm sure you want to speak to that more.
I didn't think I was taking questions today. No, that's a good point. So obviously, we always think about the issues of like overuse or doing too much in terms of causing injury, but not moving can be painful in itself. Shoulder joint is particularly susceptible, as you mentioned, to when it's not being ranged, often because there is weakness around the shoulder girdle, that it can actually become frozen, and that's really, a tightening of the joint capsule. And when you try to push through that, you can also create inflammation and then have adhesive capsulitis. So you want to prevent that by maintaining the range of motion, but that is not always possible without the help of a caregiver or a therapist, or depending on what's possibility. Generally, a therapist isn't going to see with enough frequency. You got to do your exercises on your own. And if you don't have the support to do that, not everyone does. And we recently did a case series that we're trying to communicate with the world with a group at MGH. Sabrina Paglioni and I had some people who get stuck in that state, and we use shoulder injections and then combined with physical therapy to try to get people out of that frozen shoulder state. And usually we're able to do that in our experience, but probably need more investigations into things like that in the ALS population. Yes. Who's that back there? I can't see.
Eileen.
Oh, Eileen.
Hi. My question was what Lisa answered, that physical therapy and so on, but home health can be ordered from the clinic for physical therapy in the home when patients can no longer get to the clinic, and then they can teach the family. So
that's right. So yep. So there's all, just because you can't go to the therapy gym or the hospital where the therapist is, we are able to get services often into the house. Although I know that, sometimes we've run into logistics around people who live in more remote areas too, who come to our clinic. Although I will put a plug in for both clinic visits through telemedicine, which can be possible now, but also physical therapy visits through telemedicine in the house. I'd like to transition to a new topic. And I'm going to direct this one to Lauren, but Lauren, remind me, I think we were touching around it with that shared decision making. Did you get into that question about tying back to the non-invasive ventilation, about another, not unbiased, but just like a kind of like a more neutral sort of way of getting advice? When sometimes it's hard to ask questions in the clinic.
Right. Yeah. So going back to the My ALS decision tool, it's really written from a straightforward way, right? Not leading you towards making any one particular decision, and just providing you with information. And all the things that Dr. Coleman talked about in terms of respiratory care. We also have a supplemental guide, and It's available on our website, and you guys can also stop by the table and grab that as well, because it has some key elements around respiratory care. And I think it's really scary, like, we say these words like they're easy to say, non-invasive ventilation, but what does that really mean? What does that mean when I'm in the home? How do I introduce this to my 5-year-old? These are the kinds of questions that we work through with families and talk with them and demystify the tools. So the teenagers that are the caregivers, the 20-year-olds that are the caregivers, and really helping to walk them through what this is, so they're not afraid. They're not afraid of grandma. They're not afraid of grandpa, because those are real things. But it's such a helpful tool for families. It improves speech, and it really helps, to walk people through. But again, the tool is set up to really break down decisions in a logical way, to really provide that information. It doesn't replace your conversation with your physician at all. And it's part of an education tool. I've been in neuromuscular 20 years. I hid behind these terms. I didn't really know what they meant, until I had to really explain them in a straightforward way. So we're just grateful, for the people living with ALS and the caregivers who provided the input on the resources, because they were the ones that had the editorial pen as we worked through that process.
Okay, I have another question from the live audience. Yes.
Hi, I'm just wondering, are we doing genetic testing on the ALS patients in the Lois and Solia ALS Center?
That sounds like a
And
good
how
one
does that work?
for Dr. Driss. Yeah.
That's a very good question. Yes, we are. So before, if you recall, doing genetic testing could be expensive, but thank God recently there are sponsored panels. So these are panels that allow the patient to have genetic testing, and they're paid for already. So yes, we try and have the patient meet with the genetic counselor as much as we can, but we discovered that it's impossible to have her see everybody. We are doing some of the genetic counseling ourselves and asking the patient, any new patient that we see that have the diagnosis of ALS, to undergo genetic testing if they are interested. Yes.
Can I ask a follow-up question?
Sure.
So do you mean like whole genome sequencing, or there's a platform, let's say you look
No.
at 5-10 genes, or how many genes do you look at?
Well, so we test for C9, and then there is a 21 genes that are tested for. So it's a panel of gene. We're not doing whole genome sequencing for all patients.
It's actually 31 altogether.
Yeah. 30,
You
okay.
can test for. If you select the extended panel.
Could you repeat that?
31 genes altogether that can be tested right now through Invitae for free.
So, Dr. Driss, since we're checking, are able to check patients for genetic mutations, some questions came in about CRISPR and using gene editing just to repair the mutations. Can you talk to us where that stands in terms of that, using that relatively new technology in a clinical trial or in patients?
Yes, I mean, genome editing through CRISPR sounds really great. If we can go in and cut away the abnormal gene, it would be great, right? I think Dr. Dang has an interesting experiment in the SOD mouse, but I don't think that is like stem cell therapy available yet for even considering clinical trial. We're not there yet with CRISPR, unfortunately. It's still a little bit, we want to make sure that if we cut anything, that it's okay and it's safe for the patient. So we'll have to wait a little bit on that.
And I want to tie it back to a question that came up about exercises, physical therapy, and preventing certain complications. But Dr. Maragakis, I believe you actually have a little bit of a track record now in exercise therapy for ALS patients. If I'm not mistaken, your group has published a clinical trial on this. Could you tell us where we're at in terms of because there's often a myth, probably because the disease is called Lou Gehrig's disease, that being athletic and being active could be harmful. Could you tell us what you think about what you've seen with exercise as a potential beneficial or harmful intervention in ALS patients?
I think you bring up a good point. I think that was really the genesis for our study, not because I was an expert in exercise or that wasn't necessarily part of my scientific interest, but just something that came from patients where they would say, "Oh, I was told by my physician not to exercise because it would make me worse." So we actually looked at that prospectively, and we separated patients into stretching and range of motion, resistance exercise, or endurance exercise. And the whole point was to look at the tolerability. So we did an every other day regimen, which is now published. It's the exercise strategies are there, and we focused on safety. So we had worked with physical therapists, PM&R folks, and our coordinators to design something that would be doable for patients at home. This is not something where they came into the clinic, but it's something they would do at home. And it was a very inexpensive strategy. And at the end of the day, what we showed, I think importantly, was that it was not dangerous. We had no increase in adverse events. Patients did not progress more rapidly than they would have in our standard of care group. There was a suggestion that patients who either underwent endurance exercise or resistance exercise had fewer falls, although the study wasn't necessarily powered. In other words, we didn't have enough patients to follow them for a long enough period of time to be more definitive about other potential benefits. So I think what we learned, and what I would tell patients very practically, is to do what they like to do every other day, to do it in a safe fashion. And again, the way we did these exercises is actually published as part of that article. And I do then also encourage everyday stretching and range of motion exercises, to your point about it being important for overall management.
Great. Yeah, that we're giving similar advice, I think, here. And I think, if I'm not mistaken, if you look back over decades, there was maybe 2 trials. I think there's a Cochrane review and then maybe updated in 2012 or something like this. And then in the last 3 or 4 years, there's now another 5 trials out, including yours. So, and one of them, interestingly, Dr. Coleman focused on expiratory muscle training. Do you have any comments or because this is like, we kind of get lifting weights and we're going on a treadmill, but could you talk a little bit about how you would target exercise respiratory muscles, expiratory, inspiratory, and what's the approach to that? Because, we could chat a bit more about other reasons for being concerned about it, but certainly we wouldn't want to make your breathing worse, as a consequence of trying to pursue those types of exercise.
So great question. So I think when we think about exercise, and especially respiratory muscle exercise, and you think about on kind of the paradigm of ALS and the progression of the disease, right? So I think early on in disease, there's expiratory muscle strength training. So you can use different devices that will help kind of strengthen those muscles. And it's been shown in some early literature through the speech language therapist programs that it does have some benefit. What we find more importantly, though, is that despite exercising those muscles, over time they are going to progressively get weaker. And so the most important thing is to expand your lungs and use it to make sure that you're not getting collapse of your lungs and optimizing your lung capacity. So while there's one way you can model it and try to strengthen the muscles you have, the other model that we use is what's called an exercise called lung volume recruitment. And so if you think of your lungs as like balloons that sit in your chest, and the diaphragm muscle is the main muscle that helps keep those lungs inflated. As the diaphragm muscle gets weaker, the lungs start to shrink up in size. And so what you want to do is you want to stretch open those lungs. And so what we use a technique called breath stacking. And this can be done in a couple different ways. We use it with an ambu bag, which is kind of like the bag you see on TV when they're kind of pumping air into someone. And a one-way valve. And what you do is you stack the breaths on top of each other to really expand your lung capacity to optimize your lung size. By optimizing your lung capacity, you improve your voice, you improve your ability to chew and swallow safely. And so this has a longer term effect. It's been really well demonstrated in the muscular dystrophy children's population out of Canada. so that it increases your ability to cough more efficiently and improves your efficiency to speak for longer periods of time. So I think that, while trying to train your muscles early on in the disease is a good process, over time, they're still going to get weak, and making sure that you understand that you have to think of other ways to recruit your lungs and optimize them is important.
Yeah, I'll add, we do a lot of stuff when people have just a paralyzed diaphragm, but not ALS. And what we've noticed is before they're really able to participate in active therapy to re-strengthen the diaphragm muscle, and you can see it, the diaphragm will sit quite high up in the chest. And although that we'll see evidence that the muscle recovery can happen because it's a nerve injury, not ALS. So we actually see recovery or reversal of that weakness. But then we still see that the diaphragm often sits a little higher. And we try to emphasize the breast stacking, and use the analogy of range of motion. If you had a shoulder injury, you'd stretch your shoulder out, and then you would strengthen that later. But I think sometimes it's just bears repeating. Really keeping the chest wall compliant, the range of motion, not just the lung tissue, but the muscles, the connective tissue, everything there that encases it. Because once you have contracture setting in, we know this from stroke patients, we know this from brain injury patients who get contractures. It's almost impossible to reverse contracture without more surgeries or invasiveness, which might be possible for an ankle, but we're really not an appealing thing to do for a chest. We're getting a lot of questions about clinical trials and what's coming down the pipeline. Dr. Ajroud-Driss, since you're standing up and you're so close to a microphone, I have one here. The attendee is named anonymous, but it's for Hyundai or Dr. Ajroud-Driss. Now that NU9 has a phase 1 safety trial done, what is the timeline for phase 2 trial in people with ALS, and will they be selecting for patients who have upper motor neuron onset?
Okay, I have to correct that question first because phase 1 is not done. Let me give you an update on NU9. So it was a collaborative project with me and Dr. Silverman. So we found NU9 improves the health of upper motor neurons that are diseased due to misfolded SOD1 toxicity and TDP pathology. And this was done in the SOD1 mouse model and the TDP mouse model in vivo first. Then we published in vitro that they also enhance axon outgrowth, and that is better than riluzole and edaravone. And with that, Dr. Silverman actually started the company with his sons, Akava Therapeutics. So we first get our rare disease indication approval from FDA. That was our first approval from FDA in any form. That was very good. Then we formed our board of directors, scientific board. Then we are working on our IND enabling. It's going really well. We'll submit early next year. Then the FDA will have 60 days to respond. And after 60 days, we will start the phase 1. Toxicity results came back perfect. There's no toxicity because that was actually one bottleneck that everyone was worried about. And it's clean, it's safe. Toxicity result is very good. So then for phase 1 clinical trials, is it going to be a company which does clinical trials, or will it be at Northwestern? We don't know yet, but the faster, the better. And I think after phase 1 clinical trial, then we can move to phase 2 clinical trials. And the question about upper motor neuron disease patients, and some including HSP-PLS, so that may mean a basket trial. And Merit Skovich is actually in our board of scientific board, and she's very eager, as well as Jinsey Adams. She's also very eager about basket trials. And if we get good results with phase 1, and then there's phase 2A, and there may be different branches added to this, like upper motor neuron predominant ALS patients, as well as HSP-PLS patients. And for the HSP, we are working with Dr. Bass on the spastin mouse models. We crossed them with the UCHL1 mice, and we have seen early good results. So we are actually doing the scientific investigation to understand whether NU9 would have some hope for the HSP patients as well. And if the data holds, both in vitro and in vivo, then this would give us more confidence to move forward for the inclusion of HSP patients in clinical trials. But again, phase 1 is not done, but we are moving forward.
Thank you for the correction. And in case anyone's wondering, why it takes so long and what, there's a lot of regulatory steps, as you just heard outlined. And I can assure you it's not because Dr. Osdinler isn't up all night and up early in the morning, because I get messages from her at midnight and I get messages from her at 4 a.m. So I know that she's not wasting much time with sleep or other not essential things. Oh, sorry. Pardon me, Dr. Wolf and Dr. Coleman. We're both sleep medicine certified. That meant that as a joke. So there's a question online from Klaus, which is to the whole panel, although I think it might apply a little bit more to people running clinical trials on the panel. For a patient who's interested in joining a clinical trial, where do you get truly unbiased information about the clinical trials that are out there? And they make a reference towards obviously being grateful about like the Healy platform and some of the information there, but there's many other trials and it's hard to get information. The FDA clinicaltrials.gov website, which I'll sometimes look at myself, isn't that easy to navigate for them. What's the best source of information? Dr. Driss, Dr. Ajroud-Driss, do you want to take a crack at that one first?
I would say your physician is the first step, but I agree. Sometimes the online information could be difficult to navigate. I think IMALS have a nice on their website kind of a tool to navigate clinical trial. But I will go back and say, really talk to your ALS neurologist, and they will be the ones to kind of direct you where exactly you need to look.
I also want to put a plug in for the NEALS webinars. Those are available for people living with ALS to be able to watch. So visit their website. That has a lot of really, really great information around clinical trials to kind of follow where things are in the pipeline. And also on our website, on the Les Turner website, we have a link to all the clinical trials that are currently happening, as well as expanded access at Northwestern.
I also have a question, a very specific one, about the clinical trial on high dose B12 treatment for ALS. Is there any one here could provide any information about the status of that trial, or at least, or even the rationale behind it?
Okay. What I know is what has been published in the literature. I mean, it's a small trial in Japan, showed an effect over 16 weeks, but I don't really know what else is going to happen to that. So I don't know if there's going to be a follow-up to that trial. I mean, they used the specific criteria again. They made sure patients were progressing before putting them on B12, and over 16 weeks, they did see a difference between the patient taking the high dose B12 and the patient who are not. So there was some suggestion that it may slow disease progression. I don't know what else.
I would just echo that. I think it's a really small study, and I think the time period is quite short. So I always worry about false positives, but the mechanism is not entirely clear to me, quite frankly. But I think it would be nice to reproduce it with a larger patient population.
Yes,
Like to
in the audience there, that young lady. Yeah.
I'd like to ask a question, please, Dr. Coleman. Actually, there's two questions. When is supplemental oxygen bled through an NIV? That's question number one. But the second one is, could you explain how an AirVo works?
Okay. Sure. So, like I stated earlier, most people with neuromuscular disease or ALS do not have parenchymal lung pounds, meaning there's nothing wrong with their lungs that hinders oxygen from getting from their lungs into their blood. The problem is that they can't get the oxygen into their lungs because their respiratory muscles don't work. Now, there are some cases where people may need supplemental oxygen. People who may have a history of tobacco use or smoking may have some evidence of COPD. Or there may be cases where someone has like a pulmonary embolism, which impacts the ability for oxygen to get into the blood, or they may have a pneumonia. If they do need supplemental oxygen, those would be cases where they would get that supplemental oxygen in addition to their non-invasive ventilation. It would not be replacing their non-invasive ventilation. The two would work together because they still need their non-invasive ventilation to help bring the air into their lungs. They just need a little bit more oxygen to it. An airvo, for those that don't know, it is what's called like a high flow nasal cannula or high flow oxygen. So so if you think about the way oxygen can be delivered, it can be delivered in a couple different ways. Most people are familiar with the two little prongs that go in your nose. That is low flow oxygen. And it usually is connected to a tank that you may see someone carry around or a concentrator. But it doesn't give you air very fast. It increases the amount of oxygen that you're inhaling, but it doesn't give it to you at a fast rate. An airvo is a device that can give you a high amount of oxygen and it can give you it at a high flow, how we talk about it in pulmonary. So the air can come at you very fast. So if you think about it in terms of air hunger, sometimes patients need a little bit of the air coming faster for them. Now we have looked at this in use for patients with bulbar disease specifically who can have had struggles tolerating non-invasive ventilation due to the oral pharyngeal weakness. And we have seen that it can be beneficial to give people high flow oxygen or an airvo, but not, and what we're talking about is the flow, not so much as the oxygen concentration. So they may still be at the percent of oxygen that we're all breathing right now. It just comes at them a little bit faster, which may assist their respiratory muscles. Dr. Wolf's going to add some.
Yeah, so no, just one other thing, which is that in addition, that high flow that we're talking about uses something called a Venturi force, which allows for entrainment of higher volumes, but at a different rate, which is why it's more comfortable for bulbar patients. And the other thing about it is the most efficient heated humidifier for the upper airway that's ever been invented. And so what we know is that especially in bulbar patients that have thick secretions that are difficult to mobilize, the other advantage is that it helps to loosen that so that they can keep their airway more clear. So it's the entrainment of extra volume, it's the reduction in work of breathing, it's washout of CO2 in the upper airway, but also the airway clearance.
But I will add to that. So when we talk about respiratory muscle support in ALS, non-invasive ventilation, BiPAP machines are covered under your insurance. So there are criteria that Dr. Wolf and I look for when people come to clinic, and we look at their respiratory muscle strength, we look at their oxygen levels, we look at their carbon dioxide levels, and we're trying to meet criteria that have been determined by CMS or Medicare, which has been the guideline for across all insurances. High flow nasal cannula is not currently covered under insurance. So it is a therapy that makes sense that is not covered. And so it is very hard to obtain for patients. And we are still working on how to deliver this to patients who really need it. But it is not something that is easy to get as non-invasive ventilation.
All right. I'm going to move to a few questions that are on a very specific population that can get ALS, although rare, devastating when it happens. Juvenile ALS, what causes it, and is it always genetic? Maybe I'll address this one to Dr. Driss. I can't see your facial reaction when I'm okay.
What causes juvenile ALS? I mean, we think when ALS happens in people that are young, usually juvenile is 25 and even less, we think about genetic factors mainly, even if there is no obvious gene in the family. Sometimes the gene may have skipped generation, or maybe that mutation just happened in that person. When we think about juvenile ALS, we usually think about FUS mutation. And it's interesting because there is a clinical trial now trying to turn off that abnormal FUS gene. There is also an expanded access program if patients don't qualify for the actual criteria of the trial. Unfortunately, we are not running the FUS trial or the expanded access trial, but we'll be happy to direct patients if that happens. But I don't think we know all the genes that are there that can cause ALS. And despite looking for multiple mutation, we may not find anything. And some patient with juvenile ALS may have sporadic ALS, unfortunately.
And then to follow up on that, there's a question online that I'll paraphrase about in families with a history of ALS, and how do you go about approaching the possibility of testing a young asymptomatic family member? Also, would you give them any advice for against competitive or professional sports?
Interesting. So your question is about testing asymptomatic patients.
So an asymptomatic, a young family member.
Young family member. So yeah, that's really interesting. And we make sure that the patient first meets with the genetic counselor. We want to understand depending on what the gene is. So for example, for SOD1, it does make a little bit more sense now to want to have pre-symptomatic testing because there is a trial going on that targets that gene specifically in patients who don't have symptoms. The trial is for certain genes that are known to progress fast, not all the SOD1 gene, but certainly we've seen increased in patient wanting to be tested since that happened. For other genes, really it's a little bit tricky when there is no actual treatment that is available. So we want to make sure that the patient gets genetic counseling from a genetic counselor that works with us and understands the implication of being positive or negative. Sports, I mean, contact sports, I'm against them anyway. So that's
Although I'll point out that I believe in many countries, soccer or football is European football, not American football, is very popular as a high concussion sport. In fact, the numbers probably exceed that of even American football globally by a long shot in terms of concussions. So, but what about just high levels of physical activity? Being a marathon runner,
it is hard. I mean, actually, we had a patient who ran marathon, and I mean, it can happen. So it's really it's an individual choice, but you try to counsel patients. You don't want them also not to exercise because exercise is good and important for our cardiac health. You just want them to use common sense. If they are pre-symptomatic, maybe, I don't know, would you counsel? I don't know that there are trials that tells us that you have to avoid high level, but really you don't want to have their motor neuron firing very, very, very high either. So I would just ask them to use be moderate in what they do.
Well, I think neurons require usually an excitatory neurotransmitter to drive their activation, like glutamate. And I heard something about glutamate today, someone's talk, and gap junctions. Do you have an opinion from a conceptual standpoint about the two things, Dr. Maragakis? Or even, I know that you've done some stuff on repetitive nerve stimulation and the phrenic, in terms of exacerbating things. Do you want to comment at least?
You really went back into the CV, didn't you?
I actually was following it in real time. That was right around when I started cutting my teeth in ALS. Okay. It's been more than just a couple years, but a couple years moderating the panel. Yeah.
Well, with regard to contact, I just think there are lots of different, let's say, mutations that I don't think there's any unifying, at least suggestion of my mind to say don't play soccer versus football. But to your point, I don't think those are the best things anyway. So I think if there are alternatives, I think great. Do I think playing tennis and being highly competitive at tennis and predisposes you? I don't. The point you make about the diaphragm pacing just was a demonstration that in an SOD1 animal model, that driving the phrenic nerve repetitively over time actually accelerated disease. So that was with a very specific idea in mind, but I take your point. But I think there's so much variability with how someone plays it. Football or soccer or some of these other sports that I would caution them, but for the reasons that Senda said, not necessarily because I think that repeated concussions are going to give a patient ALS.
just wanted to jump in. The National ALS Registry for people who are living with ALS right now, it's something that you could sign up for. They have risk factor surveys that they're trying to better understand exercise and other risk factors associated with ALS. And so, more people that we get completing those surveys, we can have folks better understand and analyze in addition to the other methods that scientists are using. But that's just one tool that we have to try to answer these questions.
I just looked at the clock. We're running low on time here. Lauren, I have another question for you. We're going to try to get as many in, but we're not going to get through everything that was submitted, so I apologize in advance. Lauren, we were on the topic of children, juvenile ALS, asymptomatic family members, and genetic testing. But I mean, more fundamentally, like, what do we do and how do we approach talking to a young family member whose parent or relative was just diagnosed with ALS, and how to make sense of that?
I think that's, we're looking at a change in practice and clinical practice. So there's going to be more people that are being offered genetic testing. And so this is really an important issue that we need to wrestle with and have those conversations. There's some really important key things that people who are looking to do predictive testing that they have to think about: life insurance, a whole host of things that are real life things that I think it's really important to talk with a genetic counselor. IMALS has a familial group that they meet, I think, once a month. You can go on their website, but I know a lot of people have found a lot of support and strength in communities. It's a very important topic to address, and to be able to have those conversations with your peers can be very helpful for some people. And we have nurses and social workers at the Les Turner ALS Foundation that walk through and talk with people, so they can kind of start to figure out, what are the questions that I have? What am I worried about? So starting to write those things down, and to know that you're not alone and that there is help. It is very, very challenging and very tricky as we get into these issues, but this is not new to genetic counseling. It happens in other diseases. So there are models that we can look to better support families.
Thank you. And we have a live question here from Dr. Adaway.
From all the talk today, we talked about all the great work that's beginning at the basic science level
One second, we'll have you talking to this mic.
This one's, oh, there we go.
Much better.
From all the talks today, we've learned about the great work that's been done at the basic science level, addressing ALS with the goal of eventually having more therapeutics and hopefully a cure. In the interim, I think about function and quality of life. When I think about that video earlier, the young man mentioned, I haven't heard my wife speak in 2 years. He didn't say I haven't seen her walk in 2 years. And I think communication is something that we don't talk about a lot. We have the Toby box, the Dynabox that has this, eye tracking thing. And I've seen a lot of patients who don't use it. It's not responsive enough for them. And in 2022, we have a lot of advances at the engineering side. And my question is, are there any collaborative projects that are being done with, say, engineering groups to help in terms of advances in that area to help people communicate?
I can answer that. I can answer that a little bit, and then I'll let the physicians talk. There are a number of collaborations with Microsoft and Google, and they're looking at different ways of incorporating technology and improving technology. There's a really wonderful group called Bridging Voice that is available for people living with ALS to talk with, to be able to better utilize some of their current devices. And so the technology has rapidly changed. And I think the challenge is making sure that people know that the technology is there. And that is a really important point, because it's no longer just the Toby Dynavox. There's apps, there's different strategies, there's other ways of communicating. And we had a webinar where Anne-Marie Doyle did a really important talk about voice banking, right? not being able to hear Anita's voice, that's heartbreaking. And so being able to capture the voice early on is an important way to fight back. But if somebody's already lost their voice, you can record your sister's voice. Sounds similar, right? There's things that you can do. So it's never too late to be able to figure out a way to communicate.
Any other comments from the panel? Oh, sorry, from the panel about the technology and for voice, yeah, and then.
Oh, not from the panel, from the audience.
Oh, okay.
Can
Andy?
I add to that too?
Yeah, so Annie's a speech therapist
I'm a
who has a
speech
lot of experience in ALS and used to work in a technology center at a very world famous rehabilitation hospital that's across the street.
And I will say that a big piece that we need to consider is not necessarily that the technology isn't responsive enough, but that people are not provided adequate support to learn how to maximize it. I think it's probably similar to a BiPAP. You can't just like give somebody a BiPAP and say, okay, bye, now you can breathe. Similar to a communication device, we can't just hand it over. So that's a big consideration, and ensuring that patients have access to adequate support and helping them find that is huge in increasing quality of life.
Eileen?
Yeah. Also, the collaboration with the Steve Gleason Foundation. They have wonderful support network and offer equipment to patients as well. And then, as you know, I facilitate or co-facilitate 3 support groups, and we have people from all these different companies, therapists coming to our support groups, and then make appointments with some of the people, the patients or the families, and go to the homes. So there's all of this is available.
And of course, there's more invasive devices, both planted like through this like cerebral vasculature, or where you do a craniectomy and you can implant arrays. Some of this work is actually, being led as well in aphasia from stroke and other patients who are locked in as well, where this is work is being done as well as in ALS. So the issue boils down to, even with those technologies and the rate of decoding is such that you're only getting a couple words, I believe a minute. So it's much slower than a Tobii Dynavox. And so there's clearly a need. And right now the technology supporting that type of those various levels of invasiveness and other wearables with like surface EEGs, they're just a little bit clunky, a little bit slow with some of the devices. Some of the devices are a bit invasive, but still like they're slower than what we want, because but the problem of not being able to communicate when you have pain or when you're having a new concern, or just to share how you feel as you go through this disease is a massive problem. And when it doesn't come up, fortunately, in a lot of patients to this degree, but when it comes up, it's a crisis for the family, for the patient, and for the medical team. So it's a great question, Dr. Edaway.
It's also a very nice plug for the work that we've been trying to do in the clinic, making sure that speech pathologists will see the patient even though they don't have any communication need yet, and to demystify this idea of voice banking. And start that. It's very difficult sometimes to know exactly when to talk to the patient about that. And they may not relate if their speech is still pretty good. So we've been trying to do that to make sure we start it as early as we can.
Dr. Coleman, a question came in as a follow-up about when you would introduce those lung volume recruitment exercises, when there's symptoms of involving the respiratory system or speech, or before, or at what point in the disease do you like to encourage that?
So it's a great question. So I kind of like you were talking about range of motion and talking about the chest wall compliance. I think that starting breath stacking or lung volume recruitment early on, even before you have any drops in your forced vital capacity significantly that would qualify you for a BiPAP, is a good time to do it. It's an exercise that people feel proactive about doing. So usually when I meet people for the first time, I explain kind of what the role of non-invasive ventilation is, or a BiPAP machine, how it is there to benefit them. But then I also talk about an exercise. So I think it's one of the first therapies that I start on everybody. And I would think Dr. Wolf would agree that the earlier you start it, and just keeping that range of motion and chest wall compliance is very important. People may notice a benefit, they may not, but getting in that routine of doing something that will help them every day is a good process to start.
I'm going to ask the question and try to ask it quickly. So right now, Edaravone, AMX0035, Riluzole, for example, are available to our patients. What do we know about them acting together in cooperative fashion from the clinical trials that have been done, or at least theoretically, whether or not they would, how much the combination of these drugs can augment the outcomes for ALS patients?
I think we know very little at this point, at least with regard. I mean, we have certainly had patients who have been on, potentially all three compounds, or had at least AMX0035, the components compounded for them, and been taking the other drugs. But I think with regard to any kind of rigorous long-term analysis, I think we're still want for that. So I think these are going to be very interesting days in the next, year or two as patients get on all three drugs. It may take a while for us to really appreciate what kinds of potential effects those might be. We'd love to see, a substantial effect to the point where it's obvious. If there's a subtle effect, it could take some time before we see, before we really understand that.
I agree. I think it makes sense because they don't act all the same way. So if you saw what Dr. Maragakis showed, that the pathophysiology of ALS is very complex. So maybe if we get at it from different area, we may have a synergistic effect. So it's not, they've been tried in clinical trial altogether, so it's safe to take them together. But I think we'll know in the next few years how these work together in a better way.
Sure, Dr. Osdindler. And this will be, I think, our final comment, and then we're going to move on to the next part of the program. Okay, but go ahead. I think if anyone deserves the last word, it's you after organizing such a wonderful program today. Thank you.
Thank you. But just final, this combinatorial treatment, I think, is going to be very significant as we move forward, especially the latest FDA-approved drug is a combination of two drugs, right? And because drugs work on different mechanisms and because the disease is very heterogeneous, it may be possible that combination of these drugs will have additive effect. And that's what we tried with NU9 together with Riluzole or together with Edaravone, and we showed, especially in the SOD1 system, that it has an additive effect. So I'm very optimistic that the more drugs get FDA approval, the more combinatorial effects will be very helpful for the patients. That's what I think.
Yeah, and I guess the other comment, I think I heard it in your talk today about maybe some people who are super responders to Edaravone, that they have a bigger response than the median response to like an infusion, and it could be to a pill. It's hard to pick those out of the clinical trials because the disease is so variable, but the possibility that combinations plus precision, where you match the person up with the right medication could be, yeah. I'm getting a nod there.
Yes, I would agree. I agree.
All right. I'm merely hosting the panel here. I'm not trying to offer too much of an opinion. All right. I am so sorry we didn't get through every question that was submitted. I'm really amazed at all the people still online, the people here in the audience, and the great questions that were submitted in advance and live. It's my pleasure now to introduce our leader from the Les Turner Foundation, Andrea Backman. She's been the Chief Executive Officer of the Les Turner ALS Foundation since 2015. She brings both a professional and personal passion to the ALS motor neuron disease community, having cared for and lost her mother, Sally, to the disease in 2010. She came to the ALS field following a 30-year career in business management as an institutional investment manager, including managing director of several investment firms, and brings more than 15 years of nonprofit board management experience. She has served on the board of directors of the International Alliance of ALS and Motor Neuron Disease Association since 2019 and is the board liaison to its Scientific Advisory Council. Andrea holds a master's degree in business administration from DePaul University and is certified public accountant. Andrea?
Which makes me the least scientific person in the room. Before I start, can we please give a wonderful hand to this panel? Thank you, Colin. I'm always impressed by the level of insight and really engagement at this symposium. And this 12th year is absolutely no exception. The symposium continues to grow. In fact, thanks to Dr. Osdenler and the work of her team, I'm told we have over 330 people joining us today, both here in Chicago and via the live stream around the world, which really demonstrates the importance of bringing together researchers, clinicians, people living with ALS and their family members for a day like this. So as many of us heard today, it's really a remarkable time in ALS. Dr. Maragakis talked and Dr. Driss talked about the level of clinical trials that we have today. This did not exist just a very short time ago. We are seeing approval of multiple therapeutic drugs. We're seeing improvements in assistive devices, and we're seeing increased governmental support to research this disease. I just returned from the NEALS conference. Several of you were there as well. And I also just spent the last 6 months as part of the NIH ALS strategic plan with about 50 people from around the country. And I will tell you that to a person, everyone I'm talking to is seeing pathways that will move us more quickly towards solving ALS. We are truly at a pivotal time. And actually, on a personal note, as Colin mentioned, as the daughter of a mother lost to ALS, this sort of work really pushes me to work harder every day. So I want to tell you a little bit about the Les Turner ALS Foundation, which I don't think we've talked much about here today. Lauren Webb is our Director of Support Services. Several of our support services team members and other staff members are here. But I do want to tell you about the important work we do and how closely we work with the Les Turner ALS Center at Northwestern Medicine. So we were founded 45 years ago. We are the oldest ALS organization in the country. We have funded ALS basic science research here at Northwestern since 1979. We pioneered ALS clinical care, starting one of the first multidisciplinary clinics in the country in 1986. And we provide personalized support services and a wide array of ALS educational resources to people living with ALS and their families. We are very much a partner with Northwestern on the Les Turner ALS Center at Northwestern Medicine. So not only are we a donor, and we, as mentioned, we've donated we continue to donate to support ALS research and clinical care, but we, together with Dr. Kalb, who's the clinical director, we really talk about what we can do to advance ALS research, to move forward clinical care in a more multidimensional manner, and to offer offer educational symposiums just like this. So the other thing we do very importantly at the Les Turner ALS Foundation is working directly with people living with ALS and their families. So what we're able to do is provide truly irreplaceable support and resources to the myriad of questions that you heard today, that you heard asked of this panel. Everything from what sort of supplements should I take to what sort of medical equipment do I need, when do I need it? How do I tell my children about ALS? How do I tell my grandchildren? How do I talk to my employer? How am I able to get insurance coverage? How am I going to live financially if my spouse has to quit working and support us? What are we going to do? That's where the Les Turner ALS Foundation really does this differently than anyone else. And I'll tell you this, over the past couple of years, thanks to members of our support services team, who I'm going to ask to stand, because several of you are here. If you are an ALS support services team member, come on, Don't be shy. Truly, this crew, I will tell you most recently, and these are pretty phenomenal numbers, our engagement with people living with ALS and their families, until a couple of years ago, was about 1,200 visits a year. Over the last couple years, we've really changed how we deliver our services, and we are now delivering 3,500 visits a year to people and their families with ALS. The need is there, and we're very happy we're able to serve it. The other thing that's changed is the pandemic helped us realize that there was a need around the country for the sort of services that we are able to provide here in the Northern Illinois area. And under the direction of Lauren, we started something called the ALS Learning Series a couple of years ago. It's a monthly webinar series that addresses a wide range of topics that people are concerned about that impact people with ALS. Anything from genetic testing to how to understand clinical trials to financial planning, caregiver burnout, as well as a variety of other topics. And we also created guides along the lines of nutrition to address nutrition, communication, mobility, relationships, all of the things that impact people with ALS and their families. And another major area of growth, and Lauren talked about this, is my ALS decision tool. She went into this in a lot of detail, so I'm not going to talk much about this today, but I'm happy to say that we are presenting the decision tool at posters now around the country, and it's won awards at this point, and we are looking to grow, to increase, to add additional modules because we understand how important it is to empower people living with ALS to make these important decisions. So, I want to make some thank yous because none of this happens, a day like this doesn't happen easily. I want to start off with thanking our sponsors, Mitsubishi Tanabe Pharma America, Amylyx Pharmaceuticals, Brainstorm. All these folks are here today, by the way, which is lovely. PTC Therapeutics, Biogen, New Motion, and Hillrom. We are delighted. We cannot do this work without your support. Thank you. We're also very grateful to Dr. Hande Osdenler and the Symposium committee that she headed to organize this wonderful symposium for the last 12 years. Thankful to Dr. Robert Kalb, the director of the Les Turner ALS Center, and our visiting presenters today, Drs. Lutz and Dr. Legere-Turenne, who came a long way to show us their work. So thank you very much. I especially want, and Dr. Maragakis to be our keynote speaker, of course. And I especially want to thank Frank Granata. Frank had to go home today, but he got up early, he came down here, he wanted to talk to us about his experience of living with ALS, and that's something we can never lose sight of. Also, there are many people here with ALS who either are with us today or are visiting or are seeing this live stream. Thank you. You really do push us to be our very best, and we're grateful for that. And we don't forget it. Thank you very much.